I've been at Penn since 1992. I did my fellowship from 92 to 93, and it's been great being an academic program. Our residency program is phenomenal, but even more so, it's just the partners that we have. And as Scott had mentioned, the various partners in the hand group and the other orthopedic partners. But John Kelly was very helpful for me after my firstborn. I had this just terrible olecranon bursitis. You know, it's big swelling in the back of my elbow. Just couldn't figure out why I got this. Went on and on. You know, was it an infectious process? No. Was it a traumatic process? And finally, John figured it out. At night, when I'm in bed with my wife, I heard the baby cry, and subconsciously. So, thanks, John, for all your help. Well, my charge is to review current concepts of hand and wrist surgery. I'm going to talk about a recent report in the lay literature about regenerative medicine, talk about scaphoid fractures, advances in distal radius fractures, treatment, and if we have time, carpal tunnel syndrome, but I want to leave time for a question and answer here. As Scott mentioned, we're very fortunate to have Scott here. He's been phenomenal as leadership for our department and steering it in the correct direction. But even more so for our hand surgical section, his microvascular skills coming from Duke has been just a great addition to our section. Dave Steinberg is the head of our upper extremity fellowship, trained at Penn, did his fellowship at Mass General, went out to UC Davis for 4 or 5 years and has been here within the department for the past 14 years. Well, recently in the lay literature, actually on CNN, Elizabeth Kahn reported on a patient that amputated the tip of her small finger. Full-time law student in California, said she slammed her finger in a door, sustained a fingertip amputation. She said it was this 5-week odyssey that involved defying doctors, emailing specialists around the country just to try to make her pinky finger whole again. ER physician told her couldn't be reattached. Orthopedist that saw her said can't be reattached. So the next morning she was on her computer searching for some way that she could improve the process. Emailed physicians throughout California, UCLA, Berkeley. She did find a physician at UC Davis that ended up debriding her finger and using a material called mattress stem. 7 weeks later, she said her finger grew back. Well, sure enough, there is a company, A-Cell, that makes this mattress stem. It's an extract of pig bladder. They state that it has multiple collagen types. It has multiple growth factors that are involved that provide this regenerative process to induce stem cell growth. And if you look on the web, there are multiple sites that have reported this. Lee Spivak is actually the brother of the founder of this company that reported that he amputated the tip of his middle finger back in 2005. And sure enough, it regrew after about 4 weeks. I was on 16 Minutes, and back in 2009, Oprah had this gentleman on the show. Unfortunately, there is no peer-reviewed literature about this process. There's no clinical evidence to support the claims, but sure enough, we get calls now to the office about this pixie dust, this material to regrow digits. And all the photographic evidence that we see is supportive that this healing really is just by secondary intention. And I just hope that if we do get to that point, that we don't have patients that just grow thumbs and they grow the appropriate digit. What was more concerning about Elizabeth Kahn's report is that the 5 lessons she said that were learned by this patient was realize your doctor doesn't know everything, email doctors you don't know, don't be afraid to be a bad patient. So beware of this lay literature. Well, back to some real medicine. This is a 27-year-old laborer, fell in outstretched hand, and has wrist pain. And he's tender right in the snuff box, right between the abductor pollicis longus and extensor pollicis longus. So what do we think about? What's our diagnosis? A patient has fallen on outstretched hand, radial side of wrist pain, snuff box tenderness, of course, scaphoid fracture. So what do? place a patient in a splint, make sure it's a thumb spica splint. It can be over-the-counter splint. It doesn't have to be an orthoplast or it doesn't have to be a fiberglass splint. But we need to keep that patient immobilized until we know whether there's a fracture or not, until it's been ruled out. So we get the x-rays. There are some findings in x-ray that can be helpful. We tend to get an ulnar deviation view. This scaphoid is this boat-shaped bone, and so on the typical AP, it's very difficult to assess the entire length of that scaphoid. And so with ulnar deviation of the wrist, you tend to see that entire length of the scaphoid. Sometimes you can use this navicular fat stripe. There's a black line on the radial aspect of the AP that if it's more convex, there may be some blood in the joint that may lead me to think that I have a higher index of suspicion for a scaphoid fracture. And again, I'm immobilizing this patient until I know that there is no fracture. So they come back a month later. X-ray's unchanged. No fracture in the X-ray, but still tender in the snuff box. What do you do? Do we get bone scan, MRI, or CT scan? CT? Well, first, do not get a bone scan. Very nonspecific. And if you have a positive bone scan, it just means you have a positive bone scan. You have to work it up further. So in general, if I'm determining whether there is an acute fracture for diagnosis, we tend to get an MRI. MRI is excellent to make that diagnosis of the fracture. We're going to take a look at the T2 weighted image to see if there's edema or fluid in a linear fashion. And on the T1 weighted image, you'll see some decreased signal within the scaphoid. But if I'm concerned about the scaphoid being healed down the line, I don't use MRI because an MRI is going to show changes for a year or two after the fracture. So if I'm concerned about fracture healing, I'll tend to get a CT scan. So here's our patient. Returned to the office 12 months later. Now what's the diagnosis? Non-union. How do I know it's a non-union, not acute fracture? Well, I look at the fracture site and I see that it's relatively sclerotic. She's got these smooth lines through this area. There's some cystic changes. So if it's an acute fracture, you'll see that sharp, variegated line that you don't have that smooth surface within the scaphoid. And so the scaphoid nonunion will tend to develop that sclerotic change. They'll tend to develop a cystic change. And over time, you can develop a humpback deformity where the scaphoid flexes. And as it flexes and develops this humpback deformity, you change the kinematics of the wrist and you potentially can lead to degenerative arthritis. So this patient came back a year later, has a scaphoid nonunion. What if they weren't symptomatic at all? What if they had no pain, but you just serendipitously got this x-ray and it showed the nonunion? Should we do anything about it? They're asymptomatic. Should we just, young active patient, just say, go about your way? What do we do? Well, the reason we're very aggressive with scaphoid fractures, making the diagnosis and making sure that that bone heals, is that we know that 100% of the time, by 5 to 10 years, if you have a scaphoid nonunion, you will develop radiographic signs of arthritis. And if you have a scaphoid nonunion that's been greater than 10 years, it's very, very difficult. It's almost impossible to get that fracture to heal. And over time, as we see the arthritic process, it progresses. The first stage, very early stages, we'll see some sharpening of the radial styloid. So here's the scaphoid, here's the nonunion, the proximal pole, and you see the sharpened radial styloid in stage 1. Stage 2, we'll see some decreased joint space height between the scaphoid and the radius. And so there's much less joint space height here compared to the lunate and the radius here. And it's interesting, with slack wrist, or this is called scaphoid nonunion advanced collapse, no matter how severe this arthritis becomes, the radiolunate joint space is typically maintained. You typically do not see significant arthritic changes there. We also have to be concerned about avascular necrosis. Did it lose its blood supply at the time of the fracture? And radiographically, we'll tend to see some increased sclerosis about the proximal pole. By MRI, on the T1 weighted image, you'll lose that signal about the proximal pole. And you have even worse prognosis if you have a decreased signal in both T1 as well as T2 weighted image. And the concern about avascular necrosis of the proximal pole, number one, it's going to be very difficult to get that to heal. Bone needs blood supply to heal. And if you have an avascular bone, it's going to be very difficult to heal. But then you can also have collapse of that bone. So if this fragment is avascular, it can actually collapse and then lead to further progressive arthritic changes. So scaphoid, as we said, is a boat-shaped bone covered with cartilage. Cartilage does not have blood vessels that go into it for nutrition, and so the majority of the blood supply is in the non-cartilaginous area, which is either dorsal ridge or volarly. We treat non-displaced fractures. If there is no displacement whatsoever, we potentially could treat them closed with a cast. In general, we use a long arm cast for about 6 weeks, and then a short arm cast until we know it's healed. The problem with non-operative treatment, particularly with these proximal pole fractures, if we have a fracture that's very proximal at the base, the blood supply is very poor. Remember, the blood supply to the scaphoid starts distal and trickles down within the bone. And so it can take up to 20 weeks for a proximal pole fracture to heal. We know that these proximal pole fractures, because of the poor blood supply, have a poorer prognosis. Only about 60 to 70% of these proximal pole fractures will heal. Here again is a very tiny proximal pole fracture, whereas if we're at the distal pole, close to 100% of those fractures will heal. So if we have a non-displaced acute fracture, and particularly if it's a proximal pole fracture, we'll tend to fix them. And at one time, we used to use this percutaneous screw fixation and acute fixation of scaphoids just for the professional athlete to get them moving early so they wouldn't need to be immobilized. But now we're leaning more toward fixing more patients rather than just the professional athlete, because we know that we can limit immobilization, particularly for that proximal pole injury. Rather than be immobilized for 20 weeks, we can hold that fragment in position more rigidly with a screw and allow earlier range of motion protected in a splint until we know the fracture's healed. And we know that with screw fixation that these patients have a higher union rate than the cast. Fractures displaced. Now displacement only has to be 1 millimeter or 10 degrees of angulation. You have a higher risk of nonunion. So displaced, in general, for your young active patient, you've bought yourself a surgical procedure. And in general, we use a Herbert screw, or some type of headless screw, I should say, in order to fix the fracture. If it's at the proximal pole, we take the approach dorsally. If it's a distal pole, or waist, we'll take an approach volarly to reduce or put the fracture back in position and fix it with some type of internal fixation. If it's a collapsed deformity, then we'll tend to use some bone graft in order to pull that fragment back into the appropriate alignment. And here's that humpback deformity. So this is a lateral view of the wrist. This is a patient that has a scaphoid fracture. And I know it's very difficult to see, but here's the scaphoid. And really what I'm looking at is the lunate, this moon-shaped bone. And in general, this concavity of the lunate should be pointing directly in line with the radius. In this case, it's tilted dorsally. And so as the scaphoid develops this humpback deformity, the lunate tilts dorsally and leads to this problem with the kinematics of the wrist and leads to the post-traumatic arthritis. And we can get a CT scan that shows, this is a sagittal view of the scaphoid, that shows this on the volar side, how the distal pole has flexed over the proximal pole, leading to this humpback deformity. So in this situation, where you have a humpback deformity, we tend to take bone graft. Quite often we'll take iliac crest graft if the patient has a good vascular supply to the scaphoid, reduce that fragment, and then fix it again with some type of internal fixation. Now, what if a patient has an avascular scaphoid? Well, we'd like to get vascular bone back to the area to help improving the prognosis to get this bone to heal. So in the past, we would use local vascularized grafts. There are small blood vessels that supply the distal radius. This is a diagram of the wrist from the side, a lateral view. To the right is the forearm. This is the distal radius. This is the rest of the metacarpals. And here's the scaphoid, and here's our scaphoid fracture. And off of the distal radius are some small branches of the artery, and we can take a small fragment of bone with that branch of the artery, clean out that avascular scaphoid, and take that fragment and put it inside the bone to improve the blood supply and improve the prognosis of getting that avascular scaphoid to heal. Well, an even worse prognosis is if you have a scaphoid nonunion, it doesn't have blood supply, plus it has that humpback deformity. This is a relatively small fragment. It's very difficult to get this fragment to hold that scaphoid back into its anatomic alignment. And so, more recently, at Penn, we've been using a free vascularized bone graft. And this is where the expertise of Dr. Levin has come in. That has been phenomenal in allowing us to take vascularized bone. In addition, we have a large segment of bone graft in order to hold that bone back in alignment. So actually, this is the knee. And we're taking it from the medial condyle. There's cartilages preserved. There's a small branch that comes off that we can take, the descending genicular artery, with this graft. We take to the wrist, and the hands above, forearms below. And here's our scaphoid. And there's that big segment of graft with the artery and vein. And Dr. Levin plugs that into the artery. We do as a team as we fix the scaphoid with our internal fixation. And again, we've reconstructed that humpback deformity as well as bringing in well-vascularized bone for the fixation. And it has been shown that using a vascularized graft, and particularly this free pedicle graft, tends to have a better prognosis. But what if a patient has developed arthritis? What do we do? Well, if we went ahead and fixed the fracture, the patient would still likely have pain associated with arthritis. And so once you've developed arthritic changes in your wrist and you have a scaphoid nonunion, we don't try to repair, we don't try to get the scaphoid to heal. We use what are called salvage procedures. We treat the pain. And so when the pain becomes significant enough that it's difficult to function and perform your normal activities, we have several procedures that we can perform. One is a proximal carpectomy. So here's our patient above. That is the scaphoid nonunion. You see the decreased joint space. Look, there's a minimal joint between this distal pole of the scaphoid and the radius, and the sharpened radius. Normal joint space here. We remove these three bones, and now the capitate bone, or capitate head, is running on the lunate facet of the radius. One of the problems is the radius of curvature of the capitate is not the same as the lunate, and so there is some long-term studies that have shown that that young active patient will tend to develop post-traumatic arthritis and likely require further surgical treatment. And so in that young active patient that has a scaphoid nonunion and has arthritic changes, we consider an intercarpal fusion. Remember we said that the joint between this lunate bone and the radius is typically well preserved. Here we go in the scaphoid nonunion. Big joint space here. Well, we use that joint space. We remove the scaphoid, and then we meld these other four bones together, and we run the wrist off of this joint. And there are various ways that you can get these four bones to heal. We can use your pins or screws and other plates with screws. Although it does limit the motion, at least you're able to maintain some motion and have much less pain associated with the scaphoid nonunion with arthritis. Moving on to distal radius fractures. 61-year-old female, motor vehicle accident, dominant extremity. Well, you can see the fracture, the extra-articular component here. It goes up into the joint. In oblique view, we see some comminution. On the lateral view, here's the radius that's displaced. Before we even think about fixation or cast or any other treatment, the most important component is to consider, is this a fragility fracture? Does this patient have osteoporosis? We're fortunate at Penn to have the geriatric service that takes care of any bone metabolic disorders. And so we tend to ensure with the patient that they have had the appropriate workup. Go back to your primary care doc, ensure that you've had your DEXA scan, ensure that you're on the appropriate medications if required, because there's a high rate of postmenopausal women that if they've had a distal radius fracture will have osteoporosis. And even patients younger than 45 will have osteoporosis. So make sure when you get that call, patient has a wrist fracture, first thought, is this a fragility fracture? We need to make sure the patient does not have further fractures down the line. We even did a study at Penn looking at the survival rates of elderly patients with distal radius fractures. And we know that if a patient has a hip fracture, they have a higher mortality rate. Well, it's the same in distal radius fractures, believe it or not. And we think that it's likely related that that fall that led to the distal radius fracture probably heralds a decrease in health, as well as the limited mobility, being immobilized after a distal radius fracture may lead to that process. Well, in treating distal radius, there's several factors we look at. We evaluate how the distal radius is aligned on the lateral view. We like this C-shaped ring to be tilted volarly about 10 degrees. We like the length to be appropriate, and so we're actually looking at how the radius is aligned with the ulna bone, and it should be about the same length. If there's significant shortening of our fracture, then we can develop what's called an impaction syndrome, where here's a distal radius fracture, it's healed, shortened, and now the ulna is impacting on our lunotriquetral joint. If there's significant angulation, we can have problems with the distal radial ulnar joint, where now with the bone angulated back, as after the patient fell on an outstretched hand, as they rotate, the ulnar bone becomes much more prominent. And with that displacement and angulation, the patient will have a deformity and end up with limited wrist flexion as well. We tend to use CT scan, particularly with the intra-articular fractures. It does help us better assess the intra-articular component, and it does change our treatment plans quite often. We tend to use the 3D CT in addition, since it does not have to be any other special scans in order to assess it once we get the 2D CT. And our treatment rationale is really dependent on the physiologic age of the patient, not the chronologic age. If you have an elderly patient that's very active, we're much more aggressive at making sure that patient has anatomic alignment to maintain their independence. Whereas that low demand patient that has a distal radius fracture, we can accept more significant displacement. In general, if a fracture is undisplaced and we think it's stable, we can put them in a cast. If it's displaced and we think it's going to be unstable, it's going to move out of position, then we typically treat it surgically. So in this patient, distal radius fracture, distal ulnar fracture, you can see the entire distal radius is on the back side of the shaft. Even though they've been reduced, with the comminution and the displacement of that fracture, this is a very unstable fracture pattern. Majority of these patients, if it's a young, active patient, will develop a deformity treated in a cast, and so we'll tend to treat this patient operatively. If we treat them in a cast, we'll lose the reduction. If we just use percutaneous pins, we'll tend to have collapse of the fracture. And so at one time, we used to use external fixation, a couple pins in the metacarpal, a couple pins in the shaft to hold the wrist out in position. But the problem was with pin care and limited range and RSD and other issues with the over-lengthening of the wrist. And so we tended to fix these with plate and screw fixation, initially using the dorsal approach. So we put the plate on the back side of the wrist in order to hold the bone back in position. The problem with my putting the plate on the back of the wrist, we're right next to the extensor tendon. So here's actually a plate right next to these extensor tendons, and we found a higher rate of extensor tendinitis. And if we take a look at an MRI, you can see on the palm side of the wrist versus the back side of the wrist, here are the extensor tendons right next to the plate, whereas on the palm side of the wrist, the flexor tendons are fairly far from the wrist. And you have this muscle, the peroneal quadratus, that protects us as well. And so nowadays with this we call locking plate fixation, we can fix most of our fractures even though they're displaced dorsally with a volar plate. Locking plate fixation just means that the screw locks into the plate, making a much more stable construct for our fixation. And there are various ways of this fixed angle device. Either it can be a unidirectional, and nowadays we can actually modify the position of the screw within the hole and still lock it in place within the fracture. And the volar approach has many benefits compared to the dorsal approach. It's an easier technique. It preserves the blood supply to the back of the distal radius. It's rare that we have to bone graft distal radius fractures now if we use the volar approach, and we tend to have less tendon problems. With the better fixation, we also are able to mobilize these patients more quickly. So for the volar approach, the hand is to the left here, the forearm's to the right. We'll make an incision over the flexor carpi radialis tendon. We'll retract the artery radially and the tendons and the nerve ulnarly. We'll elevate this pronotor quadratus muscle, and we'll get right down to the bone and right down to the fracture fragment. We'll reduce the fragment, and then we'll apply our locking plate in position. We'll put a compression screw initially in this oval hole, so if we're not in the correct position, we can easily slide it back and forth, and then lock it into the distal fragment. And we fill these screws with these locking holes or locking screws, and it provides much better support, because in the past, because of this is metaphyseal bone, the quality of the bone is not ideal for fixation. And so now with a locking plate fixation, we can have much more stable fixation, leading to our postoperative management be able to start earlier range of motion. So now, rather than immobilizing a patient for an extensive period of time, you can place in a splint. I typically keep my patients in a splint for about a week, and then slowly but surely progress activities after the wound is healed. We hold off on strengthening until we know that there's been adequate callus and adequate healing of the fracture. Lots of things have been tried. Ideally, we'd like to get normal anatomy, get the bone to heal in its perfect position. If I put a spacer in, one of the problems that we have just in the wrist is if you cut your ligaments, if you cut the scaphoid ligament, even with a normal bone in place, it is very, very difficult to ever get that ligament to heal, and the patients quite often develop post-traumatic arthritis. So if I remove the scaphoid and put an implant in, patients just will develop progressive carpal collapse and arthritis. And so there have been silastic implants that have been tried, there have been metallic implants that have been tried, but the wrist is a very difficult problem, particularly in this situation. Just the ligament is a problem, but have a ligament and a bone-related problem is an issue. Carpal tunnel syndrome, numbness and tingling in your hand. Typically it's activity-related, but often patients will have nocturnal symptoms. They'll have that shake sign where they have to shake their hand to try to get rid of the sensation. And from a historical standpoint, I'll try to ask the patient, now where's the numbness? Is it the thumb side of the hand or the small finger side? Most patients will say it's diffusely about my hand, but I want to determine whether it's more the median nerve distribution or the ulnar nerve distribution. So is your small finger just as numb as your thumb? And typically the patients will say, yeah, it is. It tends to be thumb, index, and long. And when I am in the office and I'm evaluating a patient, I always in the back of my head, what's the etiologic factors that are associated with this carpal tunnel syndrome? And Bob Szabo has a nice classification on assessing that etiologic factors. Is it an anatomic problem? Is it a physiologic problem? Or is it a positional related problem? Anatomic factors. Well, the nerve runs in the carpal canal. So this is an MRI of the wrist. This is the back of the wrist. This is the front of the wrist. These are the carpal bones. Here is the transverse carpal ligament, and these black things are the flexor tendons, and here's the median nerve. So anything that decreases the size of the tunnel or increases the size of the contents will put pressure on the nerve. So if you've got a mass in the tunnel, that can do it. It could be a congenital anomalous muscle. It could be a distal radius fracture. You fall, you break your wrist, you have swelling around the tendons, and that puts pressure on the nerve. Patients on anticoagulation, they fall, they develop a hematoma. That takes up more space in the tunnel and then puts pressure on the nerve. It could be physiologic problems. And we divide physiologic problems into inflammatory, metabolic, and fluid changes. Well, what are the inflammatory problems? Patients with rheumatoid arthritis, we see that rheumatoid arthritis, you see all that active synovitis on the back of their hands, all that bogginess. Well, just think about all that bogginess in the carpal canal and the flexor tendons. That's more stuff in the tunnel that puts pressure on the nerve and can cause the numbness and tingling. Metabolic problems. We know patients with diabetes, alcoholic neuropathy, as well as hypothyroidism are at increased risk of developing carpal tunnel syndrome. And then fluid changes. We know in pregnancy, more fluid on board, you're going to have a higher incidence of developing carpal tunnel syndrome, or patients on hemodialysis. And lastly, positional changes. We know that as you fully flex your wrist, or you fully extend your wrist, that tunnel gets smaller. And so the optimal position of your wrist is in that neutral position. So on examination, we perform certain provocative maneuvers. We'll percuss the nerve. We'll try to tap right over that median nerve right in the central part of my distal forearm. And I'm assessing for whether the symptoms have developed numbness and tingling in the median nerve distribution. If the patient says, it just hurts, it goes up my arm, that's a negative test. If they say that, yes, that brings on the electric shock or that brings on the tingling in the thumb index or within that distribution, that's a positive test. Phelan's maneuver. We fully flex the wrist. We hold it for about a minute. That should decrease the size of the tunnel. If that brings on the symptoms, it's a positive test. Carpal canal compression test is the most sensitive and specific maneuver that we do for carpal tunnel syndrome. Put your thumb over the median nerve. It's just the central part of the distal forearm. Hold it there for about a minute. If a patient says, yeah, that brings on my symptoms, again, a positive test. And then we have to assess the function of the nerve. So those tests are to help make the diagnosis. They're provocative maneuvers. But I need to know, am I in the mild category, moderate, or severe? So I'll assess, first of all, just looking at the hand, I need to take a look at the thenar eminence. Normally you should have that convexity of the thenar eminence when you look at both hands from the side. Well, if you have atrophy, you'll see that concavity within the thenar eminence that is more forebodes to a more severe neuropathy. And then I'll also test the strength of the abductor pollicis brevis. APB is solely innervated by the median nerve distal to the tunnel. And so I'll have the patient pull the thumb away from their palm in radial or palmar abduction and push against the thumb. If they pull the thumb straight up and they can't pull the thumb away from their palm, I know that's a more severe neuropathy. Then we'll check two-point discrimination. What's their sensation like? And I rather than just doing light touch, we need some objective evidence. And it's easy enough just in your office, take a paper clip, bend it, and the two tips of the paper clip, if it's within about 5 to 7 millimeters, a patient with normal sensation should be able to tell the difference between one or two prongs. If you have to open up the paper clip or they can't tell the difference between one or two prongs in that median nerve distribution, they've got a more severe neuropathy, and I'm much more concerned about that patient. Now, the majority of patients will ultimately get an EMG. Now, if a patient comes in the office and they say, I've had numbness and tingling for a week, I am not sending them for an EMG. If I can think they have carpal tunnel syndrome, put them in a splint, have them alter their activities, have them come back in a month or 6 weeks or whatever, and if they have persistent symptoms, then I'll consider getting that nerve study. How do I treat them? Splint, wear the splint at night, modify their activities, take frequent breaks from repetitive activities. I'll consider injecting. Now, injecting only provides temporary relief. We put the injection ulnar to the palmaris longus tendon. We're not injecting the nerve. We're injecting that bursa next to the nerve. And so we'll put a cc of xylocaine. I use a cc of dexamethasone or depomedrol in order to decrease the symptoms. But unfortunately, only about 20% of patients will have long-term relief. If a patient has a severe neuropathy, meaning they have weakness or they have constant symptoms, they need surgery. We don't just keep treating them on an operative basis because they'll have a progressive neuropathy. If they're in the moderate categories, we always try the non-operative modalities first. If they have progressive symptoms and they're miserable because they're waking up at night, that's when we start to consider the surgical options. And in the vast majority of the cases, we're considering an open release. We make an incision. It's relatively small. It's a local anesthetic. And all we do is we cut that ligament that's over the top of the nerve. It can be performed endoscopically, and that was a big fad back probably 87 was first described, and most of the articles came out about 89. Be careful with endoscopic release. It's a limited visualization, so you have a higher risk of nerve injury, but a patient that has an endoscopic release tends to have less postoperative pain and earlier return to their activities. The majority of my patients, I'll tend to do an open release, just so I see the nerve, I make sure it's completely released, and I know that they have much less likelihood of a complication in that regard.